help their parents to direct them to someone who they have.
Good morning, everyone, and welcome to this morning's meeting. Thank you for joining us. And without further ado, I am going to introduce this morning's speaker. We have a very, very special speaker with us this morning, Dr. Jared Bullard, who is a son of the soil. Presently, Dr. Bullard holds the position of Associate Medical Director at Chatham Provincial Laboratory, and he's also the section head for the Pediatric Infectious Diseases Unit at the University of Manitoba. Some of his additional appointments include Associate Professor of the Departments of Pediatric and Child Health and Medical Microbiology and Infectious Diseases at the University of Manitoba. He is also an infectious diseases consultant at Winnipeg Regional Health Authority, and he is a medical consultant to Chatham Provincial Laboratory, as well as he has been a medical consultant at Children's Hospital. He most recently completed his training as the my apologies. He most recently completed his training from 2000 to 2002 when he received a Bachelor of Science in Medicine, HIV and Immunology from the University of Manitoba. He then went on to complete his medical degree and pediatrics, after which he has done many specialties, which I'm sure he will tell you about. And so now, Dr. Bullard, thank you for joining us, and you can take it away.
Perfect. Thank you very much for the kind introduction, and good morning. Absolutely. It's a pleasure to finally be able to speak to people at home. I don't get to do it very often, so I'm very excited. Thank you, Dr. Black. Certainly, I think that everybody across the world has been dealing with this pandemic. And so what I thought would be very helpful is to go over kind of what we've seen here in Manitoba, Canada, regarding the different waves of COVID-19 that have come across this province. Like Dr. Black had mentioned, I have training in pediatric infectious diseases, but I also have training in medical microbiology. And so that's the lab side of infectious diseases. So a lot of what I do, pretty much in every facet, seems to be related to COVID-19 these days, even though I do lots of other stuff. That has been the thing that has occupied my time. So I want to disclose, of course, I have no conflicts of interest. I will be talking about some technology and testing that we use here in Manitoba, but I'm not endorsing it. It's just simply, this is what we have available. This is what we've used. The only disclosure I have is that I'm quite tired of COVID-19, as I'm sure all of you are as well. It occupies every ounce of my professional life. I come home and instantly have to start talking about it as well with family and friends. So it's taken its toll. I want to leave a lot of time for questions because I always find that when I'm giving talks, people have questions that are different than what I think I would want to talk about, but that's perfectly reasonable. Because I'm speaking to a pediatric audience, I think one of the key things is to talk about the common presentations that we would see with SARS coronavirus 2 in this population. And because I spend a lot of time also doing the diagnostic side, I think it's important to talk about that because there's definitely ideas as to what SARS coronavirus 2 diagnostics can do or what they can tell us, but there's important limitations that need to be discussed as well. And then the thing that I've been really focusing on, I'd say in the past couple of months, has to do with children and specifically the role they play in the community transmission of SARS coronavirus 2, as well as what is it like in schools and what's the evidence that we have to show that this is actually occurring. So you might wonder why I'm in Manitoba. So I'll show a picture of where Manitoba is. So on the left, you can see a picture of my father. That would be Autry Bullard. And so he is a son of Rolltown Exuma, who went to government high school and ultimately managed to get a scholarship to a Canadian university, where he happened to come to the University of Manitoba. On the right is my mother, whose maiden name was Balabuk, which is a Ukrainian name. And so that's Sharon Balabuk. And so the two of them met at the University of Manitoba, got married, and ultimately moved back to the Bahamas. Not too long after, we came here to Winnipeg, where I have lived pretty much all my life, of course, with a lot of visits to the Bahamas to see family and friends, and continue to do that. I haven't been able to in a while now, thanks to COVID, but I'm looking forward to the next visit that I can make. So the key question, I think, for pediatricians is what do we see in children? I would love to hear about the Bahamian experience. I haven't really had a chance to speak to your healthcare professionals about what you've been observing. But here in Canada, anyway, we have a population of about 35 million. When we look at the number of cases of COVID-19 in children, we know that it's about 20% roughly of the total number of cases. So that amounts to about 180,000 children who have been infected. Probably what you have also observed is that overall, it's actually a relatively mild infection in children, and that we only have 0.5% of those ending up in hospital. When we look at who ends up in ICU, that's about 0.07%, which is actually quite a bit lower than what you'd expect to see in the adult population. In addition, I'd say that the vast majority of those children who end up in ICU in this country are those who have comorbidities. So think of kids who have seizure disorders, they're premature, they have chronic lung disease, they have immune deficiencies. So all of those would account for, I'd say, the majority of children that we see in an ICU setting. And so far, this is a little bit dated, I admit, this is about a month or two behind, but there are 7 deaths in total. And you can see that that's actually a really low mortality or case fatality rate. So what about Manitoba? So Manitoba is right in the center of Canada. So it, even though you hear a lot about Toronto being the center of Canada, that's not true. Geographically, anyway, Manitoba is at the heart of the country. It's what we call one of the prairie provinces. Prairie provinces have Great Plains. And so when we say Great Plains, people underestimate what we mean. It is ridiculous, like 10 kilometers or like miles and miles of just flat. You could watch your dog run away for days and days. It's that ridiculous. Our experience actually is not that much different than what you observed in Canada, that about 20% of the children admitted are infected. Children account for about 20% of the cases of COVID in the province. Our hospitalization rate is a little bit higher, but our province also has a unique population. So Manitoba has close to about 10% of its population are Indigenous or Aboriginal population. So the common word is, you hear American Indian, same idea. And a lot of them live with very different socioeconomic status. They often live in the congregate setting, and they're in our northern communities. So that's more related to lack of running water on all of these other things that are associated with that. We have a similar hospitalization rate, though. And again, what we see when we're talking about hospitalized is it's often children who ultimately have a comorbidity. But the other key factor here is that we often are finding them incidentally. So they're being admitted to hospital, and we have a very aggressive asymptomatic screening program in place because you don't really want COVID to be transmitted within the hospital. And so we test everybody, and that's regardless of symptoms. So a lot of the time we find children who are admitted for a completely different reason other than COVID, and sure enough, they have it or had it. The testing is really quite sensitive, and I'll talk about that in a bit too. When it comes to the ICUs, same sort of thing. About 0.2% of those end up going into the ICU. A lot of those are actually the multi-inflammatory syndrome in children. And then when we talk about deaths, we had 1 death here in the province. But again, this was a kid who I think was on the tipping point of dying regardless, and was in a different sort of care program in terms of there was going to be no resuscitation no matter what they got. And I think that SARS coronavirus 2 was labeled as a cause, but ultimately I don't know if that would be entirely accurate, but we have to be careful. When we actually look at, again, what we see, and I said I look forward to kind of the question period to hear what you've been observing in the Bahamas. is mild disease. So children often walk around and they're often little germ bags, as you know, and they have all sorts of different upper respiratory sort of symptoms. It's mild. You think of things like fever, headache, and cough, and that's about 40 to 50%. But the biggest concern, of course, was that a lot of asymptomatic disease or post-symptomatic disease occurs in this population too. So they can walk around and not really have too much going on. And that was a really big concern, because if they can walk around and they're asymptomatic, but they're infected, it's possible they could be spreading it to their other family members or other children. And we'll talk about why that may not be true in a little while as well. So that's kind of been the main experience that we've had here in the province. And we'll talk a little bit about the multi-inflammatory syndrome in children as well. We've had 14 cases to date. Right now, we're in the midst of wave 3. And so this is primarily affecting a lot of the adult population that would be parental age. So think of ages 20 to about 40. And so what we expect to see very soon is a lot of these children coming into hospital with the multi-inflammatory syndrome in children. What they look like is almost a severe sepsis. So I don't know if you guys have seen too many of them. What I mean by that is they come in, their blood pressures would be soft. In other words, they're hypotensive. They often don't look very well. They're pale. When you look in their blood work, you see all sorts of indicators of high inflammation. You see white blood cell counts that are reduced because of the inflammation. And you also see some indication of a myocarditis or myocardial involvement as well. The really neat thing about these kids is that even though they look so incredibly sick, is that once you give fluids, intravenous immune globulin and steroids, they recover within 24 to 48 hours and are easily transferred out to the ward, and they get out going home in not long at all. So the experience has actually been quite positive when we look at these kids. The interesting question will ultimately be, what do we see long term? Because as some of you may know, the multi-inflammatory syndrome in children is related to Kawasaki's, which is a vasculitis. And knowing that, you wonder, will there be long-term sequelae of this infection? And certainly we're going to answer that question, because these kids are being followed quite closely. So when we first had our initial wave here in the province, we were in ramped up surveillance mode for quite a while. And so on March the 12th, over, I guess, 15, 16 months ago, Dr. Carrie Dust, who really is the brains of the operation when it comes to designing the tests here in the province, had a first positive test, and she was very excited about it. But little did she know that ultimately this would pretty much ruin our lives for a very long time. So I should point out that CADM Provincial Laboratory, as Associate Medical Director, I have a lot of different duties there. So CADM is the reference lab for the province, but it's also the public health lab. So we're responsible for surveillance for all sorts of different things, including respiratory viruses. But one of my other projects that I often work on is HIV and the other sexually transmitted infections. We currently have an outbreak that's been 10 years long of syphilis. So we see a significant amount of syphilis in pregnancy and congenital syphilis as well. But when it came to COVID specifically, we basically had to drop almost everything. And that was just to make sure that we could provide the testing, because testing was essential to the public health response. And at first, like everybody across the country, and I think across the world, there was a supply shortage and a number of things that we never anticipated having a shortage of. So we had to find all sorts of different swabs, make sure that they could actually do what they were supposed to do and get the appropriate sample. I have swabbed myself well over 50 times at this point, just to make sure that we can validate them. We also needed viral transport medium. We had to produce it, sterilize it. We also had all these testing sites across the province, so there was a lot of work that went into that. As well, when we have limited resources, we were really looking at prioritization and who should get tested and what should be the criteria. And there was a lot of discussion in and around that with all of our different stakeholders across the province. There's also all these new technologies coming in. And so at the time we were desperate. I have divination there as a joke, but there was a time where we were considering, I think we could flip a coin because some of the testing that we got was so bad. I also really got a sense of who and what people were all about. And so I wrote Getting to Know the True You. I think that stress brings out the best in us and sometimes the worst. And so you certainly got to see that. Emails, texts, and phone calls were coming at all hours, and that continues even to this day. It's not unusual for me to get calls into the evening or texts at random times. Lots of testing, lots of moral and psychological support of staff and their families. One of the key things is really keeping your staff as happy as you can, because they're the ones that are doing the heavy lifting and all the work. Looking up results and interpreting results has become, I'd say, the key thing that I'm known for here in the province, and that I often am called upon to interpret what a test means. And so that's why we'll talk about it a little bit. Teleconferences, Zoom, Microsoft Teams has become a mainstay of life. And then, of course, these results. And then media also. This is something that I didn't really anticipate having to do a lot of, but the media has considerable interest, and they have a lot of narratives that they like to push. And so there's been lots of questions coming in and trying to respond to all of those. And of course, sometimes I get to do science, and I don't consider myself a scientist. I'm too busy doing everything else, but there are key questions that need to be answered. And I'll go over some of the work that we've done. So this is an example of the amount of tests that we've had arrive in the first wave. And so this is when everybody was still kind of excited and not burned out, and they were getting swabbed. If they had an itchy toe, it didn't really matter. They were going. And so each one of those bins holds about 100 specimens. And so you can see this is 800 specimens in the second of 3 runs arriving at the lab that particular day. Why I like this picture is if you look at the medical lab technologist and her expression, I think that pretty much summarizes the feeling that was going on in the lab at the time, that it was overwhelming to get so many specimens. So it was a challenge to try to get through them as quickly as possible so that people could do what they needed to do. When we look at lab technology and the various instruments available to us, there's a couple of different things that we can do. So I don't actually know what is being used down in the Bahamas. I think, speaking to my aunt, that you probably have the gene expert. She's a nurse who lives in Florida, and she was talking about some of the technicalities. So again, I'd love to hear. And the gene expert would make sense. It's a really good instrument that isn't necessarily as complicated to use, and it has a really fast turnaround time, meaning that you can get a sample and have a result very quickly. The other 2 instruments you're seeing here are what do the lion's share of the work at our lab. And so this is the Cobus instrument and the Panther. And why they're great is that they basically can allow you to do a whole bunch of testing really quickly and in an automated fashion. So you don't have to have personnel sitting there doing this. And so it's really important to make sure that the testing was really comparable. Because you can't really be satisfied in giving a result to people where you're not sure that it's actually telling you the same thing. And so this is a study that we had demonstrating that all these different platforms were working about the same. And so the information we were giving was the same regardless of what we used. And that's in comparison to the laboratory developed tests. And so I was alluding to Dr. Carrie Dust. And so she, as I said, she developed the laboratory developed test. And so we were comparing it to that. So rapid testing is also something that's really important, and I suspect it's also utilized fairly well in the Bahamas. And so when we look at the different options out there, a lot of them were coming out at the time. And so on the far left with the orange cartridge, you can see this is the Abbott ID Now. So this is a nice rapid molecular test. It works really, really well when we're talking about screening somebody who is symptomatic, and usually within the first week of their symptoms. And we know the sensitivity is great. The specificity is also really, really good, meaning that it's not going to tell you that someone who has influenza has COVID as a false positive. It means it really is COVID that they have if the test is positive. But the major limitation is that asymptomatic, it doesn't work very well. And likewise, when it's beyond that week, it also doesn't work very well. On the far right, you can see the Abbott ID or PanBio. Similar idea. This is an antigen or protein-based test where we can screen you quite rapidly. The results available in about 15 minutes. It's similar to the other test that's molecular in that it's quite sensitive when you have someone with symptoms, and it's in that first week. If they're asymptomatic, it doesn't work very well. And if it's beyond that week, it doesn't work very well. And ironically, we just figured out recently that if you put water of any kind and just water in the cupule for the test, it comes back positive. In fact, it shows you the best positive of anything I've seen sample-wise. So plain old water can give you a false positive with this particular one. What you can see here in the middle is the Spartan. And so part of the challenge was that Canada didn't really have the ability to produce testing for COVID. And so this was their entry into the market. It basically is a fancy paperweight. It was useless. It never really did anything. And so it was unfortunate that we invested so much time and effort into making this happen. So what's important for clinicians is to appreciate, well, what is the most sensitive test that I can use? And then what is the best specimen that I can send to the lab? So when it comes down to it, any of those automated platforms are actually quite sensitive. This is a tiny little picture of Cary dust here that you can see. And so they're all really good. When we're talking about sensitivity, it's over 95%. And so they're great. In fact, the Gene Experts is probably the best one of all in terms of it often outperforms the other testing platforms we have. When it comes to the rapid test, they're basically equivalent. When we're talking about the Spartan, as I said, it's a paperweight. It's not of any particular value. One of the important things to know too is specimens. And so sometimes, most of the time, you're going to get people to send nasopharyngeal swabs. Sometimes you're going to get deeper respiratory samples from a BAL. An NPA or nasopharyngeal aspirate's not a bad idea. The only issue is that this could be considered an aerosolizing event. And so you might want to minimize doing that. And an endotracheal aspirate is also somewhat helpful. That's in an intubated patient. Sometimes, of course, you don't have the ability to do any nasopharyngeal sampling. So a throat swab is actually quite reasonable in terms of its performance. I have serum in the center there because serology is something that we looked at as well. And a lot of the testing is quite good. The major issue is that when we're talking about acute care, it doesn't work very well in terms of figuring out if somebody has COVID, and particularly in the first week. It's a little bit better between 1 to 2 weeks, and beyond 2 weeks, it actually performs quite well. And so that's why we're often using it in things like multi-inflammatory syndrome in children. I have fecal specimens as well, which can be used, but they're not ideal. And then I also have leaky specimens there because that's, as a lab person, as part of my job, leaky specimens aren't going to get processed. And so they are by far the least sensitive. And that's just simply because it's not really reasonable to expect a lab healthcare worker to go into a bag full of potentially COVID or anything else, really. So one of the key questions that was coming up in the first wave was, well, what and how long are people infectious for? And initially there was a push in the hospitals to repeat the COVID tests at 14 days. And so we really didn't think that was necessary because it would require you having, or patients having 2 negative PCRs 48 hours apart. And when I say nonsensical, what that means is that when we test for respiratory viruses, the nature of PCR is that it's very sensitive. And we knew that we could actually pick up things like influenza or RSV for weeks and weeks after somebody was infected. And it doesn't necessarily mean that somebody's infectious. It just means that the test is that sensitive and the virus may not be viable. So it really doesn't have the ability to predict infectivity. So this is a paper that we put out, which was very well received, called Predicting Infectious Severe Acute Respiratory Syndrome, Coronavirus 2 from Diagnostic Samples. And so I was the lead author working with some of the national microbiology lab people here in the province. And so it was important work because it actually was looking to define that. And what we did here was we took samples from 90 people with COVID-19. So they all had COVID. And we tried to figure out how long they were infectious because we had a cross section of people with symptoms that were anywhere from day 0 all the way to day, I believe, out to 2 or 3 weeks. And so we put them onto a cell culture and tried to determine how much virus was present. And when we looked at this, the measurement basically it tells you what we were finding. So first, cycle threshold, that is how long it takes for a sample to become positive. So all molecular technology works on the idea that you take the initial amount of nucleic acid in a sample and you duplicate it, and you keep duplicating it until you can actually pick up the signal of nucleic acid. And that's what we call the cycle threshold. So if we can have only 20 cycles required to get that signal, it means there's a lot more virus in the sample to begin with, versus if we get outwards of 30 or up to 40, it means there's probably less virus overall. And what you can kind of see with this particular slide is that you start off and you don't have as much virus, it comes up quite nicely and then gradually tails off over time. But one of the important things here too is you can see that once we get out to about day 8 of symptoms, people no longer had viable virus present. So the cell cultures were negative. So we figured out that by day 8, most people will no longer be infectious when we look at COVID in the community. But we also said that, that might not be long enough. And so what you have done, or what's been done here in the province, anywhere and kind of across the country, has been 10 days instead of the 8 days. So this is important too, in that you can see that CT values do have some important information to provide, but it's not sufficient. In other words, you can have this low CT, and if you do, it is very likely that you're going to have a positive sample, but it's not the only thing. In fact, if anything, we found that the symptom to test time, or STT, was a bit more important, and that's where we found out about those 8 days overall. But you can see that you have some crossover between those that were ultimately negative by culture. And so it's important to know that it's just one piece of the puzzle. The CT is important, but it's just as important to know how sick are they, where are they in their disease trajectory, and try to combine that clinical and epidemiological information together with the CT if you're going to use it to figure out if somebody is still infectious. And this is kind of the final graph from this particular study, where you can again see that when you first are infected, you have a little bit less virus. There's more virus as you go to a peak of about day 3 to 5, and then gradually you'll tail away from that particular amount of virus. So I'm hoping this isn't overly technical, but it's kind of an interesting finding. So the take-home points from this particular study is that, one, culture really isn't as sensitive as RT-PCR, and that's an important distinction. RT-PCR is also a lot faster. It's not really as dangerous. If you think about trying to grow up SARS coronavirus 2, you don't really want to be the person that has to do that. But ultimately, it doesn't really matter because the yield is 30%. It really is too low to be of any value, and it takes too long. So it's important to know that patients might be less infectious if they have symptoms greater than 8 days, but doesn't mean that they can't be. And likewise, the CT value, which a lot of people really fixated on from this particular work, as well as another publication that came out around the same time, there were people saying that anything with a CT greater than 25 is a false positive, which is outright not true. You can't do that. They definitely can be infectious beyond. It just meant that the cell culture system that we used and then the other study group in France used really isn't robust enough to be able to grow. And so you definitely can have people that are infectious. And so this is ultimately why removal of isolation based on PCR results was nonsensical. In fact, we still have people that are weakly positive 6 months out from infection, mostly those with lymphoma, or other hematological malignancies who are on rituximab particularly. So the key of this acknowledgement is really just that the medical lab technologists were busting themselves quite a bit to do all this work. And I was saying to public health and the clinicians that if we didn't have them, we would be completely blind doing this, and it would be all clinical. And so it's important to acknowledge that. So this is the second piece of work that came out. And as I was talking about, one, we were saying that children are more likely to be asymptomatic. Two, what was their contribution in terms of community spread and school spread? And three, when we did the prior work in the first wave, we actually didn't have any children really that were infected. I think we had one kid out of about 300 cases. And so they weren't included in this particular study. So this is the second study that was published using almost the exact same protocol. And this came out in the Canadian Medical Association Journal about 2 months ago now. And so that was important because as pediatricians, we appreciate a lot that children are not little adults. In some ways they are, but in many different ways they aren't. And so the value here was that we had a lot more children infected in the second wave, and that was from July to December of 2020. And so we took 305 samples from COVID confirmed patients. We had 97 who would be considered young children. We had 78 we would consider adolescents, and we compared them to 130 adults. And it was really important because these groupings all were from different areas within the province that all were related in somehow. So they were all from the same communities where outbreaks were ongoing. And we did the same thing. We looked at culture positivity rates. We looked at the amount of virus that was ultimately isolated from that in cell culture. We looked at the amount of virus detected by molecular methods or the viral load. And we also, again, looked at the symptom to test time to see if it was also true that children after 8 days would be less likely to have a positive cell culture. And so this is a helpful diagram to show that children truly were much more likely to be asymptomatic. One of the limitations, though, is that we were also screening these children based on often an adult contact in the home before symptoms developed, and we didn't get a chance to go back and figure out if they did develop symptoms ultimately. But a couple of things should stand out here. One, you can look at the positive culture rate and you can see that there's a significant difference between what was achieved in young children up until it gets higher when they become adolescents and then ultimately achieve these adult levels at about 44%. The symptom to test time was really not ideal because by this point, everything in and around the testing was encouraging people to go as early as possible. In the first wave, we had that luxury of people kind of casually were strolling in to get tested at different times, but not anymore. People wanted to know right away when they were infected and they would go in. You can also see that there's significantly less virus in children overall as measured by molecular methods. And then the RNase P is an important thing too, because if you've ever swabbed a child, you know how difficult that can be. They're often fighting, they're turning their heads. If the parents are trying to help in quotation marks, it's not going to go very well. But what we found was that, in fact, when we looked at the internal positive controls, the sample was actually as good. We also saw the significant difference in terms of the amount of virus that ultimately grew. So children had, when you combine the two age groups, basically 0 to 17 years of age, about 10 times less virus overall than compared to adults. And we actually tried to make sure that this was a real finding by doing these high yield samples. Those were samples from children and adults from the same community, and we had it on cell culture very, very quickly. And we knew that the CT value was low, meaning that there was lots of virus there. And even despite that, we found that children still were less likely to grow. And ultimately, the amount of virus that we got was also about 10 times less. So that's important. When we compared the two groups in terms of children who had positive and negative culture, you can see that there really wasn't that much of a difference. And the asymptomatic one is the one I would draw your attention to. It didn't really matter if they were asymptomatic versus having symptoms. And you can see that the cycle threshold was important, as was the log RNA or viral load. So that makes sense, that if you have more virus in an initial sample, it's much more likely to grow on cell culture and can probably inform infectivity a lot better as well. So this is also showing that when you look at the cycle thresholds, though, from a statistical perspective, they're not that much different. They kind of are tight all along the same distribution. But you can see that when we look at the other amount of viable virus in a sample, that there isn't necessarily as much in those younger age groups. So this looks very similar to what we saw before. The main difference is that we didn't really have the ability to say that people beyond 8 days couldn't grow virus. In fact, we didn't have more than a handful of samples in the entire 305 that had testing beyond day 6. So that was unfortunately one of the things that we could not answer from this particular study. So the take-home points from this were, one, that overall culture is still really not as sensitive as RT-PCR when it comes to the diagnosis of COVID-19, and that the yield in cell culture is actually significantly less when we look at young children in particular. It does increase with age, ultimately achieving what is 44% in adults. And that's important, right? Because if they have less viable virus that's able to grow in cell culture, it may also imply that they're less able to transmit virus between themselves, because usually they're very, very efficient at that, particularly when we look at things like influenza, RSV, or rhinovirus. But it's also important to see that the CT value that we had talked about before of less than 25 was still associated with a lack of, or still associated with cell culture positivity. So another key question that we keep getting asked about is, where will COVID go from here? And that's an important frame of mind to get into, because I keep hearing here in Canada and in Manitoba specifically, are we going to have a wave 4, or when is the next wave going to come, and can we stop the waves? And so I think it's important to realize that COVID is here to stay, vaccination, and ultimately have a reduced risk of all sorts of bad things happening to you. And so this is some work that we did as well, where we were looking to see, well, we have models of what coronavirus likes to do in Canada specifically. And so what do we think SARS coronavirus 2 will ultimately end up doing? So you'll see here that there's a lot of different coronaviruses that have been around a while. And so they have made their way into the human population from an animal reservoir. And this happened several times throughout history. So it's not really surprising that this happened here. What caused SARS coronavirus 2 to make that jump? There's lots of theories out there. There certainly is this lab escape theory, which is gaining some momentum at the moment. Regardless, it doesn't really matter. It's here. We have to deal with it. So when we look at endemic coronaviruses, those that have been with us for a long time, they show up every winter here in Canada, much like any other respiratory virus. And that just simply holds true. We also know that when we compare it to influenza A and B, a lot of the time we see influenza A first, and then right around the same time, we see the coronaviruses show up, and then the influenza B comes at the tail end of that as well. So that gives us some idea that maybe when it establishes its seasonality, it's going to be here, unfortunately, at the exact same time as influenza A and influenza B, which will make things really, really interesting this coming winter. In addition, we know that children are impacted by other viruses and can get quite sick, particularly when they're infants. So parainfluenza, enterovirus also play a role. And you can see that those often, again, are on the outside of what we would expect for what we think coronavirus is going to do, or COVID is going to do. The take-home points are that it will likely establish this endemic and seasonal pattern. It'll be here in the winter, right around all the other respiratory viruses. So testing is going to be important. It is going to be, as I said, tricky to figure out if we're dealing with influenza, RSV, or human metapneumovirus. I think the one benefit we have is that the pediatric population, I don't think, is impacted the same way clinically, and I also don't think they can spread this the same way. And that's important to point out, that one of the things we observed here in Manitoba was that when children were in school, rhinovirus went right through them. And it was spreading between the kids, it was spreading to the teachers, it was spreading when they got home to their parents and other siblings. And it didn't matter that we were doing all of these things to prevent that. So the wearing masks in school, the distancing, the hand hygiene, staying home when sick, it didn't really matter for rhinovirus specifically. It made a huge difference for every other respiratory virus, but not that one. What I also suspect we're going to see is that as the population gets more immunity, both by natural infection and as well as vaccines, you're going to see that the virulence is probably not as high. So speaking of what we've been seeing, so these are often questions that are coming up that I think we have evolving information on. And so here in Manitoba, and again, I would love to know what's going on in the Bahamas in terms of the different variants, we have a lot of the Alpha or UK variant taking over. So in the city of Winnipeg, which is the primary city here in the province, it accounts for well over 70 or 80% of all the isolates that we see. The South Africa and Brazil variants never really established themselves very well here. Now the Delta variant is a different creature. So this is the one that came out of India, in particular the second one. It seems to be more infectious than the UK variant, and that's based out of information coming from the United Kingdom, showing that it's now establishing itself quite well there. The question that we don't know yet is, one, is it more virulent or is it causing more severe disease? I think we're going to have to wait and ultimately see. And second, is it potentially a vaccine escape mutant? It doesn't seem like that's the case, because it seems like if we get one dose, probably it is not as effective at stopping the Delta variant. When we get to 2 doses of vaccine, it's a different creature. It seems like it can be stopped fairly effectively. So I know from speaking to a lot of my relatives that AstraZeneca is the primary vaccine that they have received in the Bahamas. And so here in Canada, the first one available was the Pfizer vaccine, and that's what I'd say the vast majority of healthcare workers received. It worked fairly well, but it didn't really allow itself to be used very effectively throughout the province because of the -80 requirement. And so Moderna came along, and that's what we used a lot in our northern communities. I don't know if this is applicable in the Bahamas, but people were vaccine shopping, and they still continue to do that here. That they want nothing to do with AstraZeneca anymore, except for the Gen X people. So the people who are basically about 40 to 50, they didn't care. They went out and got whatever they could get their hands on. But the younger people and the older people were all about Pfizer. That's what they thought was the ideal one. And performance-wise, it does seem like that would be the case if you look at the literature, but if you look more closely, you can see that they're all equally effective, and it ultimately does not matter what you get. The biggest concern, of course, is that AstraZeneca and Johnson & Johnson both have this vaccine-induced thrombocytopenia associated with them, but the risk of that is substantially low, really, when it comes down to it. We're talking in the order of 1 in about 200,000 to up to 1 in 600,000 vaccine doses given. And that's important because you have to provide patients and parents in particular with that context to say, you know, yeah, there is this risk, but if you get COVID, I guarantee you are going to have a much higher risk of having all sorts of clotting problems. So this is what I'm going to end on. And this is a paper that we're working on to publish because this has been pretty substantial impact. Again, I think that one of the ideas behind public health interventions was to lock down. And lockdowns were certainly important in the first wave. We didn't know anything about COVID-19 at the time. We didn't have testing supplies. We didn't have personal protective equipment for healthcare workers. There certainly was not even the idea of a vaccination being available anytime soon. And we saw what happened in places like New York and Italy, where the healthcare system got ravaged in the matter of days. And so we knew that was important. And I think that we had a lot of social buy-in from the population in general. And part of that was also shutting down schools, because we knew that, you know, when we looked at things like influenza, that infections in children herald infections in the general community. And ultimately that when we see it in children first, they're going to be driving it. We know that the rates of infection are about twice what they are typically in adults for influenza. And the assumption was that this would apply to SARS coronavirus 2 as well. The second one here was a little bit different. The vaccines were on the horizon, but the healthcare system and hospitals weren't quite ready. And so schools actually weren't shut down in that particular instance. Now in Canada, we've been going through wave 3. And so schools have been shut down in some provinces, and they haven't in others. And I think that's because we have more information kind of guiding us and telling us that well, what is the contribution of children when it comes to COVID-19, and are they in fact driving that? And so with any sort of intervention in medicine, it's not really much different when we look at it from a public health perspective. We're considering the risks and the benefits. And I think when we look at the risks and benefits specifically around schools and the community transmission, we have to look at it from the perspective of children, one, teachers, two, and also the community in general. So when we think of children, throughout this presentation, I pointed out that they have mild disease. And so them getting COVID is largely inconsequential to their own health. Second, they can't really spread it very well. And that's not just the research that we had showing something biologically different. This is actually from across the world, where we've looked, including things from Spain, where they were looking at household transmission, and they showed that kids account for maybe 7%, 7 to 10% of transmission. We can also look at school settings specifically and say, well, if they have it in a school setting and we're doing what we're doing in terms of social distancing, mask use, and hand hygiene, what is the R0? And so the R0 is a number of cases that ultimately can be spread from an individual who's infected in a vulnerable population. And typically when we think about COVID, that's somewhere between 2 to 4, depending on kind of a lot of different factors. But when we look at schools, particularly this large study with tens of thousands of children showed that, you know what, the R0 is probably around 0.3. And so that's really important. So that means that when COVID gets into a school, rather than being an amplifier of infection, it's actually a sink. So it goes into a school, and for a variety of reasons, it just ends there. And ultimately, this is not just unique to the variants we were seeing before. We know that the B117 alpha or UK variant actually demonstrates this as well. It's better at spreading infection. It's also better at making kids go into hospital, but that's just because it's more infectious in general. So then what are the risks to children of not being in school? And I think that our community pediatricians, and likely you've observed this as well, that children are not doing well being at home from a mental health perspective. There's a lot of anxiety, a lot of depression. What we're observing here a lot is eating disorders are being unmasked. We also know that a lot of children have school as a refuge. And so they come from not the best homes. Sometimes schools are the one place where they can get a meal, or this is where they get protection from their parents or somebody else who's at home. This is also where they're identified as being at risk when they're in the home setting. And so all of this is negated when you have schools shut down. So when you look at the risks to children overall, and that doesn't even talk about their development or educational or academic impacts, I think we're going to be seeing that for decades, actually. So when you look at the risks overall for children specifically, they're significant when it comes to schools being shut down. The benefits, well, if they can't get sick and they can't really spread it in either a school or community setting, again, that's not really much of a benefit for them. So what about the teachers? Because I think the teachers have been here, at least in Canada and in the province, have been very vocal about seeing themselves as one of the highest risk essential workers. And I don't know that that's necessarily true, and we have evidence to support that as well. There's several studies from across the world, and we have it from British Columbia, which is the most western province in the country, that when we compare the seroprevalence rates or the amount of antibodies in teachers to any other essential worker or other people in the community, they are actually what we would consider low risk. And so that was even before there was vaccinations in the community. So that means that what we're demonstrating in real time is this biological idea that children probably can't transmit it very well. I will say absolutely the teachers here have done a tremendous job in terms of doing all the interventions in the classroom setting to prevent infections. But ultimately, I'm not sure that it made as much of a difference as you'd expect, because we also have studies demonstrating that when we reduce the amount of interventions in a classroom setting, going from 6 to 3 feet, for instance, that the rate of infection in teachers and in their students doesn't really change. The masking thing, I don't think has ever really been proven. I still think it's a good idea just to keep people and remind them to use it. And then ultimately the community, of course, like, well, what is the contribution of children and schools in particular to transmission in a community setting? Well, that's a bit harder to figure out because of all sorts of loose definitions. There certainly could be transmission in and around schools, like if you have carpooling, and certainly if you make kids stay at home, their parents have to stay at home too often to take care of them. And so that could contribute. But ultimately, I don't think the evidence is showing that children being at home ultimately impacts the community prevalence. So children are still about that 20% of cases. Ultimately, when we look at places that have had in-person school versus remote learning, it doesn't really matter. The key thing is really the lockdown of the community in general, and specifically the adults who are the single greatest risk factor to children. And so overall, I'm not really convinced that the benefit of school closure outweighs all of these risks. So I left hopefully enough time for questions, and I hope that we achieve these particular objectives. These are my kids. This is a lovely fall day in Canada. It's hard to convince my relatives to come and visit. They don't have interest when I tell them, well, it can get down to -40, but in the summer, don't worry. It's upwards of like 80s and 90s. It'll be great. And so this is actually snow in October, which was distressing, but that's the way it is. These are my two children, Taya and Donovan. They're doomed to be physicians because my wife is also a physician. So with that, as I said, I'm happy to answer any questions you might have.
Thank you very much, Dr. Bullard, for that comprehensive presentation from your pediatrics, infectious diseases, and microbiology experience and research in Manitoba. So before we get on with the questions, we're going to ask Dr. Jessica Edwards, who's also on the call, and she is our medical microbiologist here in the Bahamas, to just give us an update on where we are with testing. And then Dr. Marcia Bassett, our pediatrician and head of department, will give us an update on pediatrics and COVID in the Bahamas, or more specifically at PMH. And then Dr. Deshawn Saunders, who's our pediatrician and deputy chief of staff, will just give us a little update on multi-system inflammatory syndrome. And then we can get on with the questions. So Dr. Edwards, you can go ahead.
Hi, good morning. I hope you can hear me.
Yes, we can.
Great. Thank you very much, Dr. Bullard, for a very interesting and informative presentation. So the Bahamas actually began testing for COVID through the National Reference Lab in about February of last year. At that time, they were using primarily traditional testing methods, traditional PCR. However, the Princess Margaret introduced testing at the level of the automated testing systems in around August of last year. At that time, I think it's quite interesting that you actually referenced two of the instruments that we are currently using. We use the Gene Expert as well as the Panther. And these systems have been very valuable to our testing methods in the hospital. We use the Gene Expert primarily for the very ill persons under investigation. And we also use the Panther for our large testing volumes. So for patients that are going to be admitted to the hospital, or those that have had procedures or are pending having procedures, surgical procedures, we also use it for outbreak investigations. So it is also a very useful test that we use. We run batches about twice a day on most days. And of course, reagents are always a concern, and preservation of reagents. The Gene Expert actually has been a very valuable and very sensitive test. And when we do comparison studies, we actually find that the Gene Expert outperforms, in some instances, the National Reference Lab or even the Panther system, because we know that it's a very sensitive test method. Additionally, we are moving toward introducing another test method called the BioFire, which is a multiplex PCR platform. And I think that this will be very helpful for our pediatric population, so we can identify viruses, not only coronavirus, but other respiratory viruses that could help in the management of patients with this particular respiratory illness. We have had some challenges with antigen testing. It's generally a very popular test method used in country, but we are not moving toward that, or we haven't moved toward antigen test system in the general hospital population at the moment. So we will use it for specific cases or concerns when we want to get a quick answer, but not necessarily on the general hospital admission basis. So we're looking at it, but we haven't moved fully into the direction of antigen testing in the hospital. I recognize your picture with the technologist, and the facial expression is something that I'm very familiar with in our setting as well, because it is a very overwhelming experience, to say the least, for having the volume of tests that come in on a regular basis. And so I just like to say thank you to our technologists that have been committed to the cause of helping in the diagnostics of COVID-19 at the hospital. Thank you.
Thank you, Dr. Edwards. Dr. Bassett?
Good morning. Thank you, Dr. Bullard, for such a great presentation. It's finally able to talk to you and see you on screen after a year of trying to get this talk off the ground. I just wanted to make one quick comment about what we've been seeing in terms of numbers of children presenting to the hospital, Princess Margaret Hospital, who have been diagnosed with COVID-19. Like your experience in Canada, we have had many who presented for other reasons, or who were being admitted for other reasons, who, by the way, turned up to be COVID positive. Our numbers as of the end of May, we have had 20 pediatric patients admitted to the Princess Margaret, 7 of whom were diagnosed with MIS-C. And I thank Dr. Sinqui for compiling those statistics for us in our department. I have a question for you, though, if you are still listening, about your criteria for testing in pediatrics at your hospital, Dr. Bullard, before Dr. Deshawn speaks?
So we have very broad testing. Every patient, and not just adult, is tested when they are admitted to hospital. The idea behind that was that we wanted to limit iatrogenic or nosocomial spread. I don't know that that's an effective strategy to use. And I say that because the RT-PCR, even though it is incredibly sensitive, really struggles when it's asymptomatic. When we get within about 24 to 48 hours, you might be able to achieve a sensitivity of 50%. And we've had numerous outbreaks that have happened, and people continue to be dumbfounded when it happens. And I was like, well, of course it's happening. So for children, yeah, the testing primarily is occurring routinely for everybody admitted to the hospital. For the serological testing, it is exclusively for multi-inflammatory syndrome in kids.
So are you saying that they get tested as they come into the emergency room or admitted to your floor?
When the decision is made from the emergency that they're coming into the ward or the ICU, they're tested, and that will be available within usually 4 to 6 hours. Because we also have the gene experts that's being used, and that's not our lab, it's the hospital-based one. But yeah, so it's not every child is tested that's in the emergency, but everyone that's coming into hospital will.
So that is exactly what we are doing. So we are very, very similar. Dr. Sinkri is telling me that we had 2 PCR negative who were antibody positive MISC cases, but the other 5 MISC were PCR positives.
And that's remarkably similar to what you see. On occasion, we're lucky and we see the RT-PCR, and all of them have serum samples that are positive.
Correct. Okay. So we are very, very similar. Okay. So I'm going to let Dr. Saunders then pick it up from here. She has managed quite a number of our MISC cases on the floor. So I'm going to let her give us a comment about what we've been doing on the floor. And then we have some other questions for you after Dr. Bullard.
All right. Good morning, Dr. Bullard. Thank you so much for a great presentation. And so, yes, similarly to what your experience has been in Canada, we have actually had cases of MISC. First patient actually came from a family island in Nagua, to be exact. And that came in around November, December. Most of our kids, they present with Kawasaki-like symptoms. They came in with the red eyes, the fever, the rash, some with abdominal symptoms, and some also even came in hypotensive, requiring presses. So our range for admissions for our patients have actually varied from as young as 17 days of age to as high as 17 in our pediatric population. Luckily for the Bahamas, so far, we've had no deaths in our pediatric population. And so most of our MISC kids, we were able to pick it up early and start treatment. So our patients were managed with the use of intravenous immunoglobulin, along with steroid usage. We would start prophylactic antibiotics pending cultures. And we also ensured that we did laboratory investigations, monitoring our inflammatory markers, looking at our cardiac markers. Most of our kids would have had cardiac workups. So initially, it was a challenge getting the echocardiograms just to look at heart function in our kids. But we ensured that we have been monitoring their troponin. For those that needed urgent echocardiograms, that has been done. And yes, I agree with you. Our bigger concern with MISC is long-term. You know, so our kids, as you say, they once treated, they are not hospitalized for a long period of time. But our question is, what's going to happen in the next few months to years for these kids? So we've had to ensure that we have close monitoring. All of our kids are followed up with our cardiologists. But the concern is MISC, yes, to date, but what's going to happen in the next year, 5 to 10 years. So with our MISC cases, only 2 cases actually presented Kawasaki-like with fever, greater than 5 days. But our other cases were all classical in terms of having the the fevers, the rash. And so we have been seeing cases similar to you. In addition, we also add in anticoagulation. And so our patients have also been started on enoxaparin. And depending on what the echo findings, some were discharged on aspirin.
That's very helpful, Dr. Sanders. Thank you.
Okay, Dr. Bullard, I guess we could get to some questions then. My question for you is, are you all vaccinating adolescents? And what has been the uptake of vaccine in this population in your area?
So we started making appointments for adolescents, so specifically 12 and up, back in mid-May. The first appointment started happening May 21st. My daughter was one of the first people to volunteer. And the uptake has been tremendous. It's interesting because that generation, we maybe badmouth them a lot, but they have this incredible sense of social responsibility. And so in addition to saying, because Taya, my daughter, fully realized that she really wasn't at risk for bad outcomes from COVID, and she knew that she probably couldn't transmit it because she lives in my house. So she decided to get it because she knew it was a responsible thing to do. She knew it would allow her to see family members. It'd allow her to potentially get back to school sooner. And importantly, she's all about seeing her grandma. And so she knows that that helps protect her. So the uptake has been tremendous. In fact, we opened up to 18-year-olds about 2 or 3 weeks before we did to the 12-year-olds. And their uptake is surpassing them. So the 18-year-olds to about 30 are more hesitant than I would say the 12 to 17. And a lot of it, I think, has to do too with parents pushing for it. But in general, the uptake has been really, really good. And anecdotally, the side effects in that age group is actually really minimal. So they're having a sore arm, whereas I found a lot of people in their 20s and 30s were knocked out. They had the sore arm, they had influenza-like illness for a couple of days, and I haven't heard or seen that at all with kids. So.
That's awesome. We have not gotten there yet. Of course, you know, we have the AstraZeneca vaccine. And there is quite a bit of vaccine hesitancy in the community. I do not know the number as of today, but, you know, slowly creeping up. I think the older population has been very good about getting in because they want to get out of the house. I think that 18 to 30 demographic has not been so great, but that's just what I've been hearing, not what I've seen in terms of government statistics. So we are looking forward to the vaccine coming into country for adolescents. The Minister of Health did make a comment a couple of weeks ago about him trying to source Pfizer for that purpose. And so we are looking forward to that happening. I'm just going to check the chat to see if there are any questions in the chat. I see Dr. Halkitis asking if the children diagnosed with MIS-C had underlying comorbidities. I think certainly in our population, we had a couple, but maybe Dr. Saunders can speak to that. But what about you, Dr. Bullard, and your MIS-C population? Were they diabetics or other underlying conditions who were diagnosed with MIS-C?
The most common feature is that they were previously healthy. And I would also say that it primarily was in the non-white populations here. So we have I have my family obviously in this room right now. We have a significant Filipino, Middle Eastern, African population. I would say that's who we were seeing it in primarily, but they were all quite well, with underlying conditions.
Okay, any other risk factors you all came up with beside, you know, ethnicity probably, that predisposed them to MIS-C?
No, honestly. I mean, the initial ones we were seeing were primarily Asian. So I think it was a Korean child and a Chinese child both came in with a much more typical Kawasaki's disease sort of presentation. But ultimately that did not continue. It was really just those two. So we were thinking, oh, this is where we're going to see it, but that wasn't continued.
Interesting. Okay, I see Dr. Chisholm has her hand up. I'm going to let her open her mic and go ahead and speak. And then we have another few questions.
Hi, good morning. Dr. Chisholm, one of the pediatricians at PMH. My question is from an epidemiological standpoint, if we were to vaccinate adults and adolescents only, how effective do you think that program can be if the 12 and under are not diagnosed? Are not vaccinated, seeing that they are not effective transmitters? Do you think we can still greatly reduce the spread of COVID and get back to normalcy even without vaccinating that population?
Right. So I'll answer that question in a couple of different ways. So I think that ultimately we have seen, and not here yet, but in other jurisdictions where they have done immunization of children earlier or adults earlier, that it does drop off quite significantly in that age group, so under the age of 12 and 10. I've often used a comparison that kids under the age of 10 are already kind of like immunized grandparents in terms of their disease severity and their ability to transmit this. The biggest issue, I think, is that we continue to see these variants come along. And my worry is that when we leave this population kind of unchecked and unvaccinated, that we could select for a variant that ultimately can spread through them more effectively. Now, that being said, we haven't seen evidence that the biology and virology of SARS coronavirus 2 changes enough that it spreads through kids easily. It just hasn't happened. So I think that ultimately the goal of trying to vaccinate the older siblings, parents, is probably the most effective strategy overall. There's also going to be studies, though, that are ongoing right now about Moderna and Pfizer in the younger age group. We have a center, we're one of the centers doing that as well. So I hope that answered your question. I think it's a great idea. I think that the best strategy would be to get those siblings and parents. And ultimately, I think it'll come down to we'll have to vaccinate that group as well, even though I don't feel as if there's going to be too much consequence to them unless this variant shows up that is more problematic for them.
Thank you, Dr. Bullard. I think one of the other questions in the chat pretty much was asking the same thing. So we're going to go to a question from Dr. Yvette Benjamin Pete. She's asking, what are your views regarding the impact of vitamin D in the evolution of COVID-19 infectivity?
Now, I'll admit that I have not read too much about vitamin D in general as it relates to COVID-19 infectivity, but we do know, so we're pretty far up north here in the province, and we have a number of children who are have quite reduced vitamin D due to sun exposure, just because when winter months come, there's just not going to be much of it. And that particular population is more vulnerable to all sorts of different infections, both viral, but in particular tuberculosis is the main one we see. So it would not surprise me if vitamin D has some protective effects. I said I haven't seen those particular studies, and it doesn't mean like consume vast amounts of vitamin D to protect yourself from COVID, because you'll ultimately just get rid of it anyway. But I think that vitamin D is a good idea for all sorts of different infectious diseases, including likely COVID.
Great. Well, I think this has been quite a good discussion this morning, Dr. Bullard, and we are so happy to finally hook up with you. And please know that we are going to be getting in touch with more questions, and please keep us in the loop with all of your research. It was great talking to you this morning and hearing your experience in Manitoba, and also great to see that our experiences have been so similar. Mm-hmm. And what we're doing is similar, and our outcomes are similar. So we're very happy about hearing your talk this morning. I'm going to turn it back over to Dr. Black for her closing comments. Thank you again, Dr. Bullard.
You're welcome. Thank you very much for having me.
Thank you very much, Dr. Bullard. And before we close the meeting, do you have any final comments?
No, it was my pleasure to finally get to be able to speak to you all. I did come and I gave a rounds in 2010, just when I first finished my residencies and fellowships. So I'm very happy to bring any experience I can for home. It doesn't happen too much, so I'm excited to do it.
Well, thank you very much. And we appreciate you waking up extra early to join us. We do recognize that there is a time difference. So thank you very much for joining us. And thank you to our Department of Pediatrics here in the Bahamas for making it possible. And we look forward to collaborating with you again in the future. So thank you very much and have a great day. Okay, and so before we close the meeting, please remember to do the feedback. It has been posted in the chat, the link to the feedback. The enrollment key is Bright Future, all lowercase, as you can claim 1.0 CME Bahamas Medical Council credit. And please join us again on the last Friday of the month, which is Friday, the 24th of June, I believe. And that will be our next CME time. As you know, it's the second Wednesday and the last Friday. It's Friday, the 25th of June. Dr. Shamanique Bodhi will be speaking to us at that time. Thank you very much to our technical team, Dr. Darren Halliday, for everything that he does to make this flow seamlessly. And please remember, if for any reason you joined us late or someone missed the talk has been taped. It's available through the University of the West Indies Sunshine Learner page, and there is a YouTube link. You can look at it and claim the CME credit after the meeting. So thank you everyone for your participation and have a great day.